Okay, while we're getting ready, let me at least start to introduce our next speaker. Many of you know Dr. Scott Rosa. He is clearly recognized as one of the premier board-certified Atlas orthogonists. You should also be aware he's director of the Trauma Imaging Foundation and chairman of research for the Upper Cervical Council, so he's a very cervically oriented guy. The other thing I would like to tell you is that Dr. Rosa would like you to refrain from taking any photos or videos of the images that are up on the screen. There's some sensitive issues and HIPAA concerns, so just enjoy the presentation, but as I said, no photos or videos. And I guess this is a good time to turn it over to you.
Yes. Thank you. First off, I want to say what a great honor it is to be here amongst such giants. I feel like I'm on the shoulders of many of these giants that have come to present today. These are people that are far more knowledgeable in the areas that they're doing than what I am, I think, and what I'm doing. But my career started as one of observation and discovery. I started looking to do one thing, and that ultimately started to pan out to see other things that I never thought were able to be seen nor understood. So just a little bit of a background. I started as a chiropractic physician. I've been in practice about 25 years. About 15 years into practice, after treating patients involved in trauma, I started getting frustrated because I couldn't understand why a certain cohort of these people would get better and a certain cohort would not. And it started frustrating me because some of them were patients I had treated prior to the crash or trauma that did very well, and then something interveningly changed. And that started me into looking into getting some postgraduate training, which included whiplash and brain traumatology, spinal mechanics, and advanced imaging. So, guess it would help if I turn that on. Guess it would help. Where I started. This is an image that started my interest into looking into dynamic imaging. I had a patient that came to me that was involved in a car crash that complained about suboccipital pain. MRI said it was normal. CAT scan said normal. I did a motion x-ray study that Dr. Frank was talking about earlier. And on a motion x-ray study, I came up with the following. Now I want you to keep your eyes right about C1. And you'll see in a moment when she gets to flexion, right there. Can you all see that? It's a unilateral C1 posterior arch fracture. Let me run it for you again. Oops. One more time. Right there. You all see it? Okay. So I get called into court occasionally as an expert witness to testify on behalf of patients involved in car crashes. And I was pulled in one day, and I used motion x-ray at the time, or had used it, to demonstrate soft tissue injuries. And when I went in, the defense attorney looked at me, and we won that case, and he said to me, motion x-ray, schmotion x-ray, MRI is the gold standard. And under my breath, I said to myself, one day, I'm going to figure out how I can see what's being inferred on the motion radiography studies in an MRI. This is the first image. I was later introduced to someone that had an upright MRI. I asked him if it'd be okay if I come down and try to position the patient in postures that I found with the motion x-ray were somewhat defining or inferring instability, and see if we can capture that with a upright MRI. And that, of course, led me to the introduction and meeting with Dr. Damadian. And from that point on, after I showed him what I had found, he had asked me, how could I help? And I said, I would like to be able to do more about seeing soft tissue injuries, because in cadaver studies, the ligaments that get damaged in this type of trauma tend to be very small. And the traditional imaging that I had been looking at up until that point was insufficient at finding it. So Dr. Demadian graciously said, why don't you bring a few patients down and we'll start scanning and see if we can help. And that started our relationship many, many years ago. And from that relationship, we've been able to collaboratively, with the support of FONAR and Dr. Minkoff and all the great engineers at FONAR, we've been able to go ahead and develop methods to be able to see this region or the cervical spine in a way that had, I believe, never been seen before. So whiplash research. As Dr. Demadian mentioned earlier, there's about 3 million crashes a year, and out of that, about 35 to 50% will never fully recover, and out of that, about 14% and or more will become disabled for the rest of their lives. I love this one. This is out of an article by the National Highway Traffic Safety Administration called Why Don't We Buckle Up? And it states that a 10-mile-an-hour collision is equivalent to catching a 200-pound bag of cement dropped from a second-story window. Anybody here ever have a patient that comes in and said they were rear-ended at about 10 miles an hour, have a lot of pain, but yet you can't find anything specifically to explain their problems? Well, there's a lot of junk science going on in the medical legal venue where they state that if you're injured or have a crash under 10 miles an hour that you can't be injured. And this is some of the things that I've set out to try to disprove and try to be able to demonstrate in court. And thankfully, with the technology Dr. Demadian and FONAR has, we've been able to do that effectively. This is one of my pet peeves that got me into wanting to learn more about advancing imaging, doing imaging in a dynamic sense, because patients don't claim to be hurting when they lay down. Patients tend to hurt when they move. So my goal was, let me put them in postures that make them hurt and see what I can find. This study showed that because the physicians that were somehow in charge of examining these patients post-trauma, because they didn't do either the right imaging or didn't do the imaging at all, somewhere between 40–30% of cervical injuries were missed. And if you look down further here, a study by Davis et al. Stated that 29% of those patients that didn't have the right imaging ended up having permanent nerve sequelae. That means because someone didn't do their due diligence of doing the right imaging post-trauma, that patient ended up at a disadvantage and possibly ending up with chronic pain. That frustrated me and was something I wanted to try to change. Dr. Demadian talked about the cervical cranial syndrome, and the upper cervical region or cranio-cervical region is the most complex region of the whole entire spine. The remainder of the spine from C2 down has interlocking facets, and the CO, C1, C2 have completely different anatomy. Inclined planes, axial surfaces, they just work differently than any other spinal segment in the human spine. They're also the most vulnerable because of the fact that somewhere close to 70% of your head turning is going to come from C1 rotating about the dens of C2, which means in order to give us the ability to turn, we had to sacrifice strength in that area. And yet that area is unfortunately an area that gets injured way too often. And it's an area that unfortunately is oftentimes not diagnosed, imaged properly, or oftentimes missed. Anyone that has followed research about whiplash will know the term S-curve. It's called an S-curve. And traditionally in whiplash injuries, it was thought that patients go from a flexion position to an extension position. And that is not the case at all. What happens is that at the point of impact, the car is accelerated. As the car accelerates, the seat back will move the torso forward, which will keep the head and neck lagging in time and space and create what is termed an S-curve. And then, of course, as the head and neck catch up to the torso and the seat back, then they'll go into an extension moment. The problem here is that you're getting a very strong translational shear force right here and a simultaneous extension force. So it's kind of like two football players hitting your knee at the same time at different directions. A simultaneous flexion and extension happening somewhere between 50 to 120 milliseconds. And muscle guarding does not take place until 200 milliseconds. So in some manner, some of these folks are injured before their head even has a chance to hit the head restraint to try to mitigate some of the force that's imparted into them. So this is what the S-curve looks like. Retraction of the chin into the neck. And it happens within 50 to 120 milliseconds. This is an example of a low-speed crash, 8.6 miles an hour. Head acceleration is 15 Gs. For any of you that fly an airplane, watch right there. For any of you that fly an airplane, I don't, I'm under the impression that you start getting up about 2 or 3 Gs and you can start to pass out. Well, this is accelerating the head at 15 Gs. There's your translational shear force right up at the top. Followed by rebounding of the torso because the seat back will ramp up energy and will want to throw the torso forward, only to be met by a shoulder harness. That shoulder harness will ultimately restrain the torso, but then continue to cause a re-entry phase of strain into the posterior portion of the neck, right there. And this is where we start to see these range of injuries that were not being looked at. And it's no disrespect to the radiological community. It was just something that they probably might have not been understanding or trained in. And we know that we're looking mostly for cord compression, herniated disc, neuroforaminal stenosis, nerve compression, but not many that I've met initially in my work were looking at things as the soft tissues, such as the stabilizing ligaments of the neck and the cranio-cervical junction. Here's another one, a frontal. And I show you these to try to get a sense of the straining loads that can be imparted into the cervical spine. Doesn't look like much. Big, strong guy. But when you're watching in slow motion, watch. So who volunteers for this? Not me. I always get asked that question. They get paid $250 for the day to do that. But I will say, I will say in respect that these people submitting themselves into the crash testing are people that are in the perfect scenario to be crashed. They know they're going to be hit. They're in perfect position. They're not like everyday accidents that would happen where you can be at a stoplight, you're not paying attention, you have your head turned. They're under ideal circumstances. They're not in this to be hurt. So everything that can be done to keep them safe is being done. Dr. Madian.
Scott, I wanted to catch you before you change that picture.
Yes, sir.
All right? Because I think that in terms of understanding this phenomenon, we have to put the blame where it belongs. And what I mean by that is when I went to medical school, I graduated in 1960, there was no such thing as a whiplash injury. It didn't exist. And all of a sudden, there's an epidemic of whiplash injuries. Where is it coming from? My hypothesis, it's a hypothesis, is that it's coming from the thoracic seat belts. And take a look at that. His shoulders are restrained and his head's whipping forward. And you're having the same thing going on with childhood autism. These children are sitting in these infant seats, they're strapped across their chest, and the only thing that's mobile is their head and neck, and they're ending up with childhood autism. I think that's where the blame is. I don't know what to do about it, but I think that that's the origin of all these whiplash injuries.
I would agree with Dr. Jamadian, and I'll add to that, that from the research, prior to 1984, any of you that had a 79 Cutlass, when you got rear-ended, the bumper would crumble, the hood would crumble, the fender would crumble, and oftentimes the seat back would either deform or collapse. What that did is it took the energy from the striking vehicle into the vehicle that it was hitting, and it absorbed it. And it also created time. That time was able to allow the occupant to somehow brace or grab onto something. And in 1984, after the insurance companies cried to the car manufacturers, we're spending all this money repairing vehicles. Can't you make a stiffer vehicle that's more crash-worthy? And of course, the car manufacturers said, we could do that. So what they did is they created rigid bumpers and seat backs. And when that happened in 1984, that Dr. Madian will also remember, the amount of injury went up over 274%, I believe. And the reason being is that now with a rigid bumper and seat back or the onset of SUVs with ladder frames, when the vehicle got so rigid, when the striking vehicle hit the target vehicle, instead of the vehicle deforming and absorbing the force and energy transfer, the energy now got transferred into the occupant, and then the occupant became a projectile inside the vehicle, only to be met. And we tell everybody you have to wear your lap belt and shoulder harness for preventing ejection. But the science and research has shown exactly what Dr. Madian said. shoulder harnesses and lap belts increase your risk of injury. Absolutely will increase it. In fact, that's one of the primary risk factors for increased injury along with head restraint geometry. So, and this is something that we can't get away from because the 5-star crash rating that you see on TV, that's good if you're the insurance company not wanting to pay to repair the vehicle. But it's not good if you're the occupant. Okay.
I think the point is that all the impact momentum as a result of these shoulder straps is being transferred to the head and neck.
Absolutely.
The head and neck is absorbing it all.
And it's just like being in a car crash where you get rear-ended and then get sent into someone in front of you. It's bad enough to get a force imparted into your spine from the rear, but then to have a subsequent hit into the frontal area is a double injury or double stress or strain to the cervical spine. Question? Yes?
Is there any discussion on what the airbag does in this?
Airbags, unfortunately, is similar to that of a lap belt and a shoulder harness. Lap belt, shoulder harness prevents you from ejecting. Airbags do have some benefit under catastrophic conditions, but unfortunately, if it's not a catastrophic condition, extremely high-speed crash, they actually will have an injurious effect, yeah, unfortunately. In fact, there have been airbags that have knocked people out and killed people. Yeah, no question about it. This is an interesting one. This is a side impact. As you see, they pushed the car into her. Interesting story, I like to tell it. This gal is a defense doctor for the insurance company. And she came down because she wanted to show that people don't get injured in car crashes. Now watch the car coming out from under her, and watch the lap belt and shoulder harness is going to restrain her torso, and watch the grimace on the face as the neck goes into lateral flexion. So when she got out of the car, and by the way, this is a very low speed, head acceleration is 4.6. She got out of the car and said, "I didn't move." And we said, "Yeah, you did. We got it on video." And she goes, "No, I didn't." And we said, "Come back and look at the video." And she said, "I didn't move." Well, she came down the next day after and quit. And hopefully she went back and told the insurance companies that car crashes can hurt people. So with that, again, discovery and observation. I wanted to know what kind of pathophysiological stress might occur to the human cervical spine when you put someone in an S-curve. So what I did was I tried to reproduce that. This is a neutral position. Obviously, it's a neutral sagittal MRI. We put that patient's neck, chin into retraction, and it wasn't as extreme as an S-curve could be, but look at the cranial elements as they start to be pulled caudally. Now, if you think about that, if you add in the extension moment of the mid-lower cervical spine, the potential for downward caudal tension and stress, I think, is huge. And it's something that led me to continue to look further on, which you're about to see now. So this led us to, one day I went and I took 7 of my whiplash cases to an upright MRI facility. I scanned all of them and went home that evening, and at 2 o'clock in the morning in my pajamas, I was looking at those 7 imaging studies and found 5 out of the 7 had low-lying cerebellar tonsils. And I said, what's the chance of 5 out of 7 people in my small town being on the same day brought to an imaging center and all having Chiari malformations? The answer is it's impossible. It's impossible. So I called up one of my co-authors, Dr. Freeman, who's a forensic trauma epidemiologist, and I said, "Dr. Freeman, Michael, have you ever heard of low-lying tonsils in whiplash?" He goes, "Well, no, why?" And I said, "I just found this non-specific finding." I said, "What do you think?" He said, "I think we ought to get more images." So I then was able to get a hold of 50 more upright MRI images with people that had a history of MVC, people that didn't. And then at the end of this journey, we ended up getting 1,200 MRIs, as Dr. Smith discussed this morning, 600 non-trauma, 600 trauma. Out of each cohort, 300 were scanned upright, 300 were scanned recumbent. As you see here, what we found was you're 4 times more prevalent in a whiplash-injured neck pain patients than neck pain patients with no recent history of trauma to have cerebellar tonsillar ectopia. Now, we like to define that there is Chiari malformation, the traditional Chiari 1. There's certain radiological findings that one would expect to see. You might have a syrinx. We believe that our observations were more of a traumatic-induced, whether there was something pre-existing before then, settling low or not. We can't really be sure of, but we did go ahead and look at the numbers. And of course, when we published our article, and I bring this to your attention, you see here under trauma, see this right here, an upright? Okay. to add on to Dr. Smith this morning, our grading system was 0 being at foramen magnum a millimeter above or below, +1 is 1 millimeter up to 3 millimeters, +2 is 3 to 5, and then -1 was -1 millimeter to 3, and subsequently -3 to 5. What we found was, though, there was a reasonable amount of cohort that had them subtly at foramen magnum or lower, and I'm going to present later my thoughts about that, and I really believe that while the 23.7 was the one we published, and that was because we understand that the radiological community, to some degree, still thinks that 5 millimeters or less is a nonspecific finding. And I don't think that's correct. I think that that needs to be redefined. And I think that whether, I use the analogy, if you have a bottle of wine and you take the cork out and then you're not done with it, you put the cork back in, it doesn't matter whether the cork is 1 inch in or 1/4 of an inch in. It's still going to block the fluid from coming out. And later we found that to be the case. In fact, Dr. Milrot did a study and found that sometimes the cerebellar tonsils can be thick and juicy like snails and wrap around the brainstem and not be that far down through the foramen magnum, but yet if they obstruct the flow of spinal fluid and the clinical symptoms are that consistent with Chiari types of syndromes, then it's considered to be a problem. So I don't think that we need to be worrying as much on how far they are. I think we should be more concerned on are the clinical symptoms consistent with that of Chiari, and/or is the spinal fluid obstructed in a manner that could contribute to the clinical symptoms? Okay. So as we found, in the 1,200 patients, the tonsillar atopia was identified in 1 of 4 trauma patients compared to 1 of 18 non-trauma. So my point with this whole thing here is that above and beyond the upright being more sensitive and specific to finding them, I think we need to be more vigilant at looking for this finding, because this finding, in essence, is what has become the basis of the foundation of where we are evolving to. What I know now of images I took 3 years ago is amazing compared to the time that I took them, and obviously we're all observing similar findings. This is exactly what we use. This is a normal. This is the exact patients that I used that day. That was one of them. That's flexion. The dentate ligaments, Dr. Bradley, thank you. There are very few people talk about them. Chiropractors know very well about them, but the dentate ligaments are the structures that anchor the cord inside the center of the canal. They are horizontally placed at foramen magnum, and then they are caudally angled each segment beneath it. So in flexion, there is absolutely going to be more of a caudal tension and pulling on those structures when one goes into tension, which is what we expected to see. There's another one. There's another one. Difference between recumbent and upright. Obviously, we're not only seeing, in my opinion, further distension, but what we're seeing is when you lay down, look at the difference here. You're seeing mechanoreceptors come into play. When you're in a gravity environment, the mechanoreceptors feeding back to your brain is telling you where your head and neck should be in time and space. When you lay down, those mechanoreceptors are going to shut down, hence the difference of why we want to image patients in an upright posture rather than a recumbent posture when it comes to the spine. Just my opinion. Just to review, it was ironic, but you all realize that 1/3 of the neck doesn't have any discs, and yet that's the things that we most look for. We most look for, is there a herniated disc? But yet 1/3 of the neck, the most important part that we're coming about, doesn't have any discs. But it does have a lot of structures that are not only important in stabilization, but when those structures are damaged, they are innervated with nocioceptors, meaning they have the capacity to generate pain, unlike other ligaments that don't. So these are the stabilizing ligaments at the skull base: posterior lanto-occipital membrane, posterior lanto-axial ligament. You've got the apical ligaments and so forth. And yes, in trauma, they do disrupt. They disrupt, they tear. I'm going to show you a few of them. Question?
You mentioned ligaments that do not generate pain. Are there any ligaments in the lower cervical spine that do not generate pain?
No, when I'm talking ligaments that don't generate pain, there are very few ligaments, if any. The anterior longitudinal ligament is extremely innervated with pain centers, nocioceptors. PLL, interspinous, capsular ligaments create over 54% of neck pain in a whiplash injury is coming from a facet capsular ligament. And it's a structure that we're not even able to visualize it unless you do a motion radiography study or you do an interventional block is a good way of seeing that. But all those structures are innervated with nocioceptors. Yeah. Alar ligaments, very important. Very important. They are stabilizers. And ironically, most folks think of them as inserting, coming out of the posterior portion of the dens, inserting into the occipital condyle, but there are somewhere close to 40% to 50% of patients that have a rudimentary attachment of the alar ligament to the ring of C1. And that's not something that many folks recognize. What we are missing, as Dr. Smith showed this morning, we do this for trying to, my hopes are is that when you go back to work Monday, that there'll be things that you can take home from all of our presentations, certainly this one in terms of trying to educate you about what to look for. But the most thing important is when you go back and patients are complaining, ask for their MRIs. Start looking at them. We're not trying to step or outstep radiologists. We're trying to raise the bar so that we can look for things that are suspected to be red flags. And then when the patients complain that they're not getting better, we can go ahead and say, you know what? I think that there's a suspicion that you might have something at your cranio-cervical junction. You might need to go ahead and have some more advanced imaging taken of that area that would better be able to define what's going on there. So ligaments, as we know, they should be black and contiguous. Essentially, it's a simple, straightforward concept. When ligaments are disrupted, they'll thin, and they'll start to have signal intensities put within them. This is a perfect example of some fairly catastrophic tears. I mean, the posterior atlanto-occipital membrane, the atlanto-axial ligament, tectoral membrane, that should be continuous black lines. Those are not. And I cannot tell you how many patients' images I get per week from around the United States and out of the United States that have imaging studies that were said, as Dr. Maiden said earlier, no discs or no disc pathology, compression, nerve irritation, and so forth, nothing found. Normal study. But yet I'll find a catastrophic tear in a tectoral membrane or posterior atlanto-occipital membrane. And when I tell the patient, I think we found where the area where your problem is coming from, their answer is, you mean to tell me I've had this for 10 years and no one ever told me? And the answer is yeah. And it happens all the time, sadly. But we're trying to change it. That's why we're all here today. Here's a perfect example. On the left, right out of the textbook, tectoral membrane, thick collagenous architecture. See this right here? That is what's left of the tectoral membrane. This is a gal that flew in from Sweden who was in a car crash 13 years ago, suffering in chronic pain for 13 years. Her original MRI had that in there. It was never mentioned. And no disrespect to any sort of treatment or therapy, but in Sweden, they told her, we're going to put a skull cap on you, going to put a weight on that skull cap, and I want you to do this. And now, 13 years later, she's suffering terribly, resultantly from someone not having the right diagnosis from the start. My feelings are, if a patient's not responding at least 50% or more better in 4 weeks, stop wasting time. Send them for an MRI, get the imaging done, because that imaging could be the difference of not only giving them the dignity of a diagnosis, but it's also the starting point to know what treatments are going to be best suited for them and what treatment might be contraindicated. And it doesn't mean the person that has the contraindicated treatment is doing bad treatment. It just means it's not the appropriate treatment for the condition. Alar ligaments, pretty straightforward. They should be black and contiguous. This is what we would consider a grade 3 alar ligament lesions bilaterally. The grading system is 0, 1, 2, 3. Grade 1 is 1/3 of the length of the ligament having a signal intensity. Grade 2, of course, is 2/3. Grade 3 is through the whole course of the ligament. And you can actually see there's a complete disruption right there. There's the cortical margin of the alar. That's a little disruption within that structure right there. The cruciate part of the transverse, pretty straightforward. These are things that can be seen today. We have the technology, we have the ability. The cranio-cervical sequences that we're using are able to see this. These are proton density images that we use. That's what the research experts say are best for it. And we use them. And to remind you, alar ligaments, innervated by nociceptors. Dr. Smith, I believe, spoke about Dr. Bogduk. Bogduk was a guy that mapped this all out. Alars have nociceptive capability, transverse, tectoral membrane, 1/3 up to the clivus can generate pain, posterior atlanto-occipital membrane. These are all structures that are capable of generating pain. So if your patient is claiming that I got suboccipital pain and it's radiating up and it's radiating around, and the MRI says no herniated discs, I'm going to tell them, well, you got no herniated discs. Then what? Then what? At least if you know that this is the problem, then you can refer them out to the appropriate people, whether it be a chiropractic treatment, whether it be a pain interventionist to try possible facet injections or blocks. But as I say, most of the studies being done today are not addressing the cranio-cervical junction. They start at C2 down, as Dr. Dmanin says. Transverse ligament should be black. Here you go, bilateral grade 3s. This patient just so happened to have low-lying tonsils. And I'm telling you, folks, there is more out there than we have ever imagined. Sadly, my observation has been is that the image that's mostly used to assess low-lying tonsils is sagittal image. And I think they're the least sensitive image to look at, which I'll demonstrate in a moment. There is the corresponding axial view to that coronal view. So I believe that the sagittal imaging alone is insufficient in diagnosing CTE. I think you need a three data set study. I think that the coronal is probably the most sensitive if sliced and positioned properly. And then the axial is second, and I think the sagittal will be third. Here's an example. Anybody here, other than some disc protrusion down about there, anybody here think that those tonsils look relatively low? I don't think so. Well, what about that? Same patient. Now, my colleague, Dr. Freeman, God bless his soul, he doesn't let me get away with anything. He is a pit bull. And he said, well, how do I know that that's the slice we're looking at? And I said, you're right. So let's take a look. So, of course, the red line represents the slice. And if you see up here, 17 of 24, 17. So that's showing us what slice position we're seeing the structures that we're looking at. So that's 17. That's 18. Tonsils looking pretty low. Now let's take a look at the axial. We're looking at slice number 10 of 24. We're out of foramen magnum. We're out of the foramen magnum. Let's go to slice 11. We're still out of the foramen magnum, and it's still tonsillar material. So, is sagittal enough? No. When I mentioned earlier about the 76% in our study, that was done with sagittal imaging only. So now the question is, if we had axials and coronals on all those people, how many of the percentage would it have been? And I think it's probably a lot higher than we thought. This is a gal that flew in from New Mexico and kept telling the doctors, I don't feel well, my spine hurts, my neck hurts, I got dizziness, nausea, facial pain, I have cognitive issues. So we did a cine study on her. Now I'd like you to all keep your eyes right there. Watch it rock back and forth. That is, in my opinion, from what you described it for crash, that was a translational shear force that just went right through that area. There's interspinous ligament disruption, ligamentum flavum. I think the PLL is disrupted in the ALL, and as the disc is rocking back and forth, she's getting discogenic pain. Every time she flexes and extends, that disc is just deforming back and forth. Outer third of the disc has nocioceptors. So if the disc is rubbing back and forth, what are the chances of that pain generating in a discogenic manner?
How is that image generated? Is the patient moving? Or
Yeah, well, what we do is we acquire a series of images. They're about 11 seconds each, and then we interpolate them with FONAR's great software, and we make them into a movie. Yeah, we've got plenty of them. Yeah. When we're suspecting instability, we want to go ahead and know. As I mentioned earlier, motion X-ray was a great start for me. It infers bones going in places they shouldn't. But I want to know what's going on with the soft tissue subsequent to those bones moving beyond where they're supposed to. Wrong diagnosis. Same scenario. Looks like a fairly good sagittal MRI, other than a mild bulge mid-cervical. This was a very interesting case. Dr. Bender, my colleague, this gentleman was in an offset frontal crash, commercial airline pilot, and he claimed every time he would turn to the left, he would just about faint, pass out, and then ultimately have a shock-like shooting pain into his left leg. So what we did was, I had never done it before. It was an experiment. I said, well, let me go ahead and turn you from side to side and see what happens to the vertebral arteries. So this is what we got. Now, just to orient you, we're looking at an axial view from the top down. There's a ring of your atlas right over here. And you're going to see the vertebral artery. Watch. Now, they will tend, one side will shut down a little bit compared to the other in rotation. But if you look at the reading right side, that thing will shut down pretty close to done. Watch. Right there. So that's how come when he turned his head one way, or plausibly that might be why. And ironically, he did have a study done where they did do this type of study, but they did it from C2 down. And if I'm not mistaken, Dr. Bender will refresh my memory. If I'm not mistaken, the neurologist said, you guys are too low. You need to be checking the vertebral arteries up at the cranio-cervical junction, not at C2. And ultimately, when we did this for him, same scenario. We gave this gentleman the dignity of a diagnosis. We started treating him. Dr. Bender's been treating him. He's stabilized. He's doing wonderful. Now, that guy could have been, and I believe he went around the country to Mayo and various other places. He could have spent the rest of his life trying to figure out, why am I getting dizzy and almost passing out when I turn one side to the other? Another one of him, we talked earlier about how inflection, and this is something I'm observing, inflection, oftentimes you can get a budding of the brainstem, and what I am observing also is somewhat of a tethering and stretching of the spinal cord in certain cases when they have certain conditions. So watch here, right about there. So you got this disc anchoring the cord here, and then you've got the capsular portion of the dens starting to abut, and look at what it's doing to the cord. Same guy. Now, is it plausible that some of this stuff going into his leg might have been coming from that? Well, if a myelopathy and a spur can go ahead and cause issues in the lower limbs, why wouldn't that? He would have never known if we weren't able to go ahead and use the technology to go to try to figure this out. Okay. This was him on a static view. Neutral posture, the anterior tubercle is abutted up to the dens. Inflection, the ADI opens up. It's fairly consistent with what we found with his transverse ligament and alars. Okay. Get to the fun stuff. So I have a patient who went ahead, his mother, they drove in from Michigan, and the story goes that the kid was in a car crash, kept complaining he was having these bad headaches, kept complaining that when he laid on a pillow, it was excruciatingly hurting him. The pediatrician, after 2 or 3 years, said, well, the mother said, well, I want to take him for some better imaging. And the pediatrician said, I think you're becoming hysterical, and if you don't stop, I'm going to call child services and have your kid taken away from you. True story. So the first image we did was a proton density sagittal. And anybody want to take a look at those tonsils? Okay. And that's just the, here, I'll show you the coronal. These are the axials. Let's take a look. What's happened with that? Why is that cut off? Okay, so we are essentially now out of foramen magnum. The reading left, which is the right tonsil, is sufficiently through the foramen magnum. And of course, he did have transverse ligament lesions. But here was the compelling thing about this pressure in the back of his head. So we went ahead and we did a, oh, here's the, I'm sorry. Here's a coronal. Here's the alar ligaments. How's that for tonsillar ectopia? We gave these images and printed them on glossy paper and told the mother to go back and tell the doctor respectfully, we appreciate your input, but you're fired, and next time before you go ahead and draw a conclusion, why don't you go ahead and let the parent dictating that the kid is not doing well be the guide. Okay. All right. Next. Here's another case. This gal came down from Canada. Same thing. She had a car crash. She threw up every day for 3 months. Kept telling the government, who runs the healthcare, I'm sick, I'm not feeling well, and I can't lay on the back of my head because every time I lay on the back of my head, I get pounding pressure headaches. So we did a flow study on her, and we found the following. See that right there? Can you all see that? As you speed that up, that fluid is impacting the back of the brain. Is it inflammatory? That's where she said it hurt. I would have to defer to people a whole lot smarter than me with the CSF flow at this point, but I couldn't imagine that's a comfortable thing. And I will make comment that we've seen this in several cases where the bone looks as though it's starting to erode from that pulsation of that spinal fluid with the cardiorespiratory cycle. So. Okay. This is a very interesting study. So when we started looking at these aberrant spinal fluid flow studies, I started to see indications that spinal fluid, when obstructed, when it couldn't get out of the foramen magnum, started to have these aberrant patterns of flow. And that flow could be maldirected or backjetted in any manner back towards the brainstem. And we started with the onset of the technology being able to see some of these things. So this was the first image that I took that actually took that thought and hypothesis, can fluid actually be misdirected in a manner that it can impact tissue? And let me go ahead and blow this up. I want you to keep your eye right on the cerebellar tonsils and take a look at that. I think it's pretty, watch. Wagging like a dog's tail. Every cardiorespiratory cycle. Is it possible that when fluid with every cardiorespiratory cycle, 70 beats per minute, as it continues to hit that tissue, can it cause that tissue to become injured, damaged, deteriorate, degenerate? And that's what we're trying to find out. We're trying to find out if these aberrant flows impacting brainstem, spinal cord, and/or brain tissue could be manifesting in deterioration of that tissue. Okay? So that led us on to further studies. Just bear with me a moment. Okay. So what we did was, oops, already open, sorry. So what I did was I did a study about 2 years ago. And it was just non-specific study because I had seen a lot of cerebellar tonsil ectopia and whiplash. I said, why don't we just take a cohort of whiplash people and do pre and post studies, pre and post treatment, the treatment that we render. And we did about 43, and we found out of the 43, 4 had MS and 2 had Parkinson's. But yet the common thread was they all had an atlas misalignment or malrotation, they all had cerebellar tonsil ectopia, and they all had CSF obstruction. And that's what led me on to saying, maybe we need to look at MS and Parkinson's separately, and which is what we did. So another couple of examples. So this is an MS patient. We just spoke about, can aberrant spinal fluid flow affect brain tissue? So what we did, whoops, hold on. I don't know why this is doing this. On the left is the pre-treatment, and look at the signal intensity right back in here, and I'm assuming that's turbulent flow. This is after a C1 atlas correction. Now, I still am concerned about, is it plausible that that pulsating CSF is causing an erosion to that bone? I'm not the expert in that, but right here you see a signal intensity lighting up, and you can see a deformation in that cortical bone. This is after the treatment. That signal intensity stopped. But yet that disruption or the...
Is that one treatment or a course of treatment?
This was within, I'd say, about an hour. Yeah, we do our studies pre and post. Very compelling. Here again, and again, as I mentioned when I started, these are of observation. This one is very profound. This is a young boy that has MS. And this is his imaging study before we treated him. And I will ask you to go ahead and look at the level of the brainstem, and I'll point it out. What we're seeing there is a signal intensity lighting up. And that was within each cardiorespiratory cycle. So that was in before treatment, and let me go ahead and compare the after treatment. And after the treatment, not only does the signal intensity get less, but here it looks as though that spinal fluid is coming right off the clivus bone and somewhat impacting at that level, whereas after the treatment it seems to be coming in a more smooth stepwise flow pattern in front of the cord. So I went ahead and I said, you know what, so where these signal intensities are lighting up, again, is it possible that that fluid hitting tissue can deform it in some manner? So I went ahead and I looked at his static brain MR. And we looked at his coronal. And as we went into the coronal, what we saw was the following. There's your lesions. Sorry. And when we talk about dentate ligaments, we're going to talk about cord distortion, because when we see C1 misalignments, the work of a Dr. Grostic, who the chiropractors would know of, stated that when an atlas misaligns more than 3/4 of 1 degree, that it'll pull the cord to that side of misalignment. The only method or manner that which that could happen is with the dentate ligaments. So not only does he have cord distortion, but it's too ironic that these signal intensities are showing up at the level where the spinal fluid is hitting the tissue. Do I have the answers? No. Is it something we need to look into? Yes, we are. Very, very compelling.
He doesn't have MS?
Oh, yeah, he does. He's in a wheelchair. Oh, he's in a wheelchair. Oh, yeah, yeah, yeah. And by the way, a clinical story about him. He came into my office, young boy, 24 years old. His nystagmus was so bad, he couldn't read. It was just this. And after treatment, within about 6 weeks, 4 to 6 weeks, that nystagmus has stopped completely. He's still in a wheelchair. And of course, those lesions in the brainstem, I think, are probably going to preclude him from regaining the ability to walk. But his quality of life has improved dramatically, and he's doing wonderful. So,
Scott, if the
yes.
common denominator is CSF obstruction, what determines which neurodegenerative disease you get?
We're getting to that. Thank you for asking. Okay. It's hypothesis. That's all I have. And I have people that are a lot smarter than me to answer to. So what the thoughts are is that, and there's been things written about this by other doctors, Dr. Schelling, Dr. Flanagan. But the thought is that when you get obstruction of spinal fluid and it can't make it out of the foramen magnum, again, it can become turbulent. It can start to turn around and backjet, and where that backjetting goes can depend on what tissue might be affected. The other part of the equation is, depending on the angle of the clivus bone and depending on the angle of the posterior fossa, might very well dictate where that fluid is going to manifest in terms of what it might be hitting. This is an example of a Parkinson's patient. This was one of the most interesting cases we had ever seen in one of our research projects, and we have a bunch of my colleagues here that were there for that day. But so this gentleman has Parkinson's, and I had never seen a turbulent flow pattern like this, ever. That looks like an upside-down vortex of a tornado. And I'm not the radiologist, but my colleague, Dr. Harshfield, stated that he felt that that fluid was going retrograde. So the substantia nigra is right up there. So is it plausible that that backjetting of that fluid could be turning that fluid or backjetting it up towards the substantia nigra? And the answer is, it's plausible. So with all my colleagues with me that day, I said, I've seen a lot of these and I've done a lot of these pre and post treatment. I said, I don't think that's going to change much. So what we did is we treated him, and then we did a post study. And the post study actually showed some improvement. So there is less of the backjetting, but what you'll also see, I believe there's a better flow, downward flow, as compared to the pre. But ironically, and there are people here to validate this, we went out for dinner. This gentleman left. In fact, a very funny story. When we put him in for the post study, he went ahead and said to the tech, "Can they hear us?" And she looked around and she goes, "No, why?" He said, "I think they're all crazy." True story, swear to God. And she goes, no, you have to be patient. Dr. Rosa does a lot of these. You might be surprised. So he gets out of the scanner. I get a phone call. We went out for dinner, a bunch of my colleagues here, and a phone call states, he gets on the phone and goes, I got to be honest with you, he goes, I was real skeptical about being part of this research project, but I was more skeptical about the chiropractic part. And I said, I appreciate your honesty. He was an hour down on the New York State Thruway and said it was the best he felt in several years. So we did something. I can't explain everything yet. As Dr. Friedman says, we have a lot more questions and answers, but something changed in our before and after treatment, and it obviously reflected in how we felt. Okay. Alrighty. So there are numerous things to review here. Now, here's another example. This is a gentleman that went ahead and came to us, non-remitting headaches, and same scenario. He was found to have low-lying cerebellar tonsils. And he had tried various types of treatment, had a bad outcome to one treatment. Dr. Harshfield sent him up to me and said, scan him and try to fix him, because the last time he had a treatment, he had to go to the emergency room. So we went ahead and we did a treatment, and it doesn't happen like this all the time, folks, I can assure you. But what we did was, put it this way, we corrected his atlas, and this is fairly close slice for slice, and those tonsils migrated up. And the only intervening thing that was done was the atlas correction.
Why?
Because I believe that when the atlas misaligns, that it goes up and around the occipital condyle. Due to the dentate ligament attachments, it's causing a caudal sideward pull. Dr. Todd Olson, the head of the anatomy department at Albert Einstein Medical Center, called it the cork in the mouth of the bottle syndrome. And he said there is no other plausible explanation unless there's a new structure that the anatomists don't know about. And we see these all the time. Here is it.
Do you demonstrate, along with this flow study, the actual malalignment of the atlas by CT, X-ray?
Oh no. Well, traditionally we use X-ray. Let me just get back to the flow study. I think you guys will like it. We actually, when we do a correction on a patient's atlas, we take a set of three-dimensional X-rays, and that gives us the coordinates of where the atlas is misaligned, and then we make a correction, and then after the adjustment or correction, we take a post-X-ray to make sure that we've reduced the misalignment. What we're doing now is we've advanced that. I'm using the MRI now. We do what's called image-guided atlas treatment, because I have found things on the MRI that the X-ray doesn't show, and we'll hopefully get a chance to see that shortly. So here's his pre and post imaging studies, and I think that we can get, Dr. Bradley can opine that when you look at the anterior portion of the brainstem, you'll notice on the cardiac, on the CSF flow cycle, that it's staying dark. And I'm assuming that that means that it's not going through a traditional diastole, systole. It's just staying dark. So I'm assuming that that is, pardon me?
Maybe the vertebral artery.
Well, then if that's the case, then here it is after the correction. That's pretty interesting. This is it after the atlas correction. So was it the vertebral artery or was it flow turbulence?
You don't know, maybe you're slightly off.
No, we have the scout views are pretty well slice for slice. We're pretty good with that. So, and that corresponds to the post MRI showing the migration of the tonsils up. So, okay. Let me get you some others. Now, here's another one, a very dear friend and patient and colleague of mine who's in representing the CCSVI Alliance. Her grandson at 11 years old was found to have lesions in his brain. And we went ahead and we did a pre and post imaging study on him with treatment. They were gracious enough to fly out. This was his imaging study before the correction. There's that darn signal intensity. That was him before treatment. I also draw your attention to the disturbance in flow. The tonsils are low. We know that from the static imaging. But there's not very much, if anything, going up the retrocerebellar space. That was before treatment. And this was after. And it's a much improved flow pattern. Now, the interesting thing again is we want to know, so where the signal intensity is, if there's smoke, is there fire? So let's take a look at his static MR. And this is what we found on his static MR. Here is his axial flare. And if we go and we use the scout view, we'll go up. And remember, the signal intensity was at the bottom of the cerebrum. And you're going to start to see lesion load. Is it correlating? Maybe. It's right in that area. Yes, yes, we have. We haven't done a post MRI yet, but the patient is doing well, and that'll be something we'll do in the future for sure. Okay. Lastly, and there's several of them, I wanted to show you another example. I think this is a really good example of aberrant flow and its potential to impact soft tissue. Let me blow this up. I want you to keep your eye right over here. As that spinal fluid comes down the anterior frontal space of the brainstem, watch what happens to that fluid. It's lighting up the brainstem. It's almost like it's actually, I'm not sure if it's eroding the clivus and making a hook, but somehow that fluid is impacting that structure and it's showing up as a signal intensity. Again, observation. Okay, I know we got to get going here. And I would like to show, I was asked to. So if any of you that have been following the Dr. Zamboni's work, the discussions have been problems with jugular flow, obstructing the jugular flow. And what we did was, this is just out of observation, Sharon came in for one of our research studies, and she had a confirmed stent that was successful, but it was found on ultrasound after to not be flowing any fluid. So this is her before treatment, and this was her after. And we're seeing fluid moving through it.
What is that work? I'm not familiar with it.
Zamboni's work is that his observation has been that jugular obstruction or insufficiency of outflow is what's contributing to MS. So his answer for that is to go in and do either a venoplasty or put a stent in. And they've had some good success with some cases, and some cases have not. And what we're finding is we actually did a study of 11 confirmed cases of venoplasty and stent that didn't have a good outcome. And we did pre and post treatment studies on all of them. And all of them showed more of an equilibration of the jugular vein flow after atlas correction than before. So now the question is there another component that's being missed in the jugular obstruction model? And I think that that model might be that when the atlas rotates, it very well can be compressing or altering or somehow influencing that vessel, that fluid flow, through the jugular and the carotids, which we see. So, okay. All right, get back. Alrighty. So these are just some observations at the cranio-cervical junction. What we're looking for from a chiropractic perspective, or the cranio-cervical syndrome, as Dr. Demadian discusses, we look at where the lateral mass is in relationship to the condyle. And on this side, you'll see that it's in fairly good proximity with the occipital condyle. Here, you'll see that it's somewhat translated forward. That's the good side. That's the side that the atlas misaligned on. Here's another example. And of course, there are some in the medical and chiropractic community that don't think the atlas can move, but this is a perfect example of the atlas literally riding up the occipital condyle. And I think Dr. Bradley now, with somewhat of a vision as it goes up that articulation with the attachment of the dentate ligaments, it's plausible that it might be causing a downward caudal pulling. Low-lying tonsils. This is C1, C2. These are the malrotations Dr. Demadian is talking about that we work with. This is a very complex case. Gal had excruciating headaches, pressure, nausea, dizziness, the whole gambit. That was pre, and that was post. These are some of the, and again, I can't say that the more malrotation, the worse the disorder, but these are cases, not only is there malrotation, but the scalar ligament is insufficient. There's a movement of the anterior ring of C1 away from the dens. There's instability in there. This is an MS patient. That's a dementia patient. That's a Parkinson's patient. That's pre, that's post. This is something that I mentioned earlier when I think Dr. Frank asked, how do you assess this? We use traditionally X-ray. The problem is that in some patients' X-rays, we can't see this. This is a malformation of C2. You got the body turned and the spinous is not commensurate with the positioning of the body, vertebral body. So when we do our analysis of getting our vector, we do an analysis of the lower neck angle based on the center of the dens and the C2 spinous in the lower portion of the neck. Well, if that is deformed, whoops, that's going to throw that lower angle off. Therefore, that will throw our vector off. And this is why we, in complex cases, oftentimes will find that some of the cases that might have been treated successfully to a point where the patient might have plateaued, we come in there and look at the MR and find that there might have been something that we can find that can help alter that vector and get a better outcome or a better correction. We call it the image-guided atlas treatment. This is essentially what we do. It's a table precision instrument, no pain involved. That stylus does not push in like a plunger. It's not a drill press. Essentially, the X-rays and the MRI give us the exact coordinates to create what we call a vector. The vector is the angle at which we position that instrument to gently tap the atlas into alignment. Essentially, this is what it looks like. That's it. So my thoughts are for the future, or my vision is FONAR dynamic MRI should become the primary means of diagnosing spinal trauma. And I believe cine MRI and CSF flow studies should become a standard of imaging when a patient is showing signs of tonsillar ectopia, suspected instability. And I think that we are on the verge of learning enough. We got to bring other people in to help. Thankfully, we got such great minds here. But this plausible connection between neurodegenerative brain disease and aberrant spinal fluid flow and CTE and atlas misalignments, I really think that we're onto something. I think that it's not the full answer, but I think it is a part of, or a piece of the puzzle that has not been looked at before. And I think that we all need to continue to work towards that end of figuring it out. So with that, thank you.